So I'm going to go ahead and introduce our speaker today. It's my pleasure to introduce Dr. Kruse-Jarres, is how most people pronounce it, although that's not the proper German pronunciation, who's an associate professor of medicine at UW in the Hematology and Oncology division. She started her career at Tulane, where she got her MD and MPH, and then went on to complete both a general Hem-Onc fellowship as well as additional coagulation training under a training grant from the National Hemophilia Foundation at Tulane. She started on faculty there as well, where she was the director of the Adult Sickle Cell Center, both at the Tulane Center and the Southern Louisiana Center. Was also the associate director of the Louisiana Center for Bleeding and Clotting Disorders. And then in 2014, she moved to Washington and became a associate professor of medicine here. She's also the director of the Washington Center for Bleeding Disorders. She is the president, also newly, the president-elect of the Hemostasis and Thrombosis Research Society. Really, she's spent, in her non-clinical time, aside from the administrative piece, has really spent an extensive amount of time researching hemophilia from early on in her career, with a particular interest in acquired hemophilia. She has extensively investigated the use of immune modulators for prophylaxis and treatment of inhibitors in hemophilia, as well as investigating the patient immune response with the use of these agents. She's worked to create national hemophilia databases, as well as to characterize the epidemiology and treatment practices of hemophilia internationally. She has published extensively in these areas. She has taught extensively in these areas, and that's what she's here to teach us about today. So please join me in welcoming Dr. Kruse-Jarres to teach us about the developments in the treatment of hemophilia.
Thanks, and thank you so much for having me here. It's really an honor to speak to you about something that I'm very passionate about, and that's hemophilia. Hemophilia is evolving very rapidly, and the management is changing, and I really enjoy this opportunity to kind of bring you up to speed as to what's happening in hemophilia. These are my disclosures. I certainly have been a scientific consultant to all of these companies that are making clotting factors or agents for hemophilia, and I received some research funding from them. So what I want to do in the next hour or so, I just kind of want to review hemophilia just a little bit to get everybody up to speed, and then I want to point out what the biggest challenges in hemophilia are today. And from there, I want to go and update you on what's going on with the ultimate cure, which would be gene therapy. Where are we at this point? Is this going to become reality? And in the meantime, what do we have to offer to these patients? And I'm going to point out some subcutaneous, longer-lasting therapies, one of them which was recently approved. So real quick again, hemophilia is an excellent recessive disorder. It mainly affects males. Women and daughters are usually what we call obligate carriers, and we're really not thinking about those obligate carriers as much anymore as they really have, or a lot of them do have, mild hemophilia. So there's more and more attention being given to these women, but we're not going to talk about that today very much. The incidence of hemophilia has not changed. Why is that? There is prenatal testing, there is counseling. We see that there's a spontaneous mutation rate in hemophilia about 30%. So we get new cases all the time without a family history. So therefore, this is ethnically and racially an equally distributed disease. The degree of severity is the same in all family members because the mutation is carried on, and that determines the severity of the disease. Hemophilia A is a deficiency of factor VIII. It is about 1 in 5,000 and is much more common than hemophilia B, which is a defect in factor IX. Here, just to remind you, no coag talk without the coagulation cascade, but just to see where we are. And like I said, the severity is assigned by the factor level, not a phenotype or a bleeding phenotype, but more their factor level. And what's important to keep in mind for this talk is that somebody with severe hemophilia is somebody who pretty much has no clotting factor. They have less than 1% clotting factor, whether that's A or B. And then we talk about moderate and mild. And we're always thinking that the people that have spontaneous bleeding or have the most severe bleeding are those that have the severe disease with a clotting factor of less than 1%. And you'll see why that's going to become important here. So the bleeding, the common bleeding sites are soft tissue, muscle, joint bleeding that is of particular concern. And we certainly see life-threatening CNS, neck, throat, GI, retroperitoneal bleeding. But what we're spending a lot of our time on is this joint bleeding that eventually leads to this kind of picture. Thankfully, in this country, we don't see that much anymore, but I certainly have many patients that come to us, to the Washington Center for Bleeding Disorders, that come from other countries that still present with this picture. And what's happening here? Well, you have the joint, and if you have bleeding into the joint, the synovium right here is going to have an inflammatory reaction. You get synovial hypertrophy, whether that is from hemosiderin or from some inflammatory cytokines. We're still trying to determine, but one bleed can lead to this reaction. And there is a very nice publication that came out recently that showed that there is not only hypertrophy, but there also is neovascularization in the synovium, and that probably leads to bleeding over and over and over again, and more blood kind of stirs this vicious cycle. And what happens eventually with this blood that's very toxic to the joint, we see osteochondrial destruction, then eventually destruction of the bone and an end-stage joint, such as that loses mobility, causes a lot of pain. People are in wheelchairs and crutches. So this is where we don't really want to be anymore. This is where hemophilia comes from. So historically, hemophilia has been around as long as mankind. We know that. But there really hasn't been a treatment. So the mortality for people with hemophilia was, with severe hemophilia was in childhood, maybe up to their early 20s. But that was the life expectancy. All we had in the 1800s was maybe blood transfusions that seemed to do something. Then later on it was discovered, well, plasma is even better and cryo is even better than that. But that was the treatment we had. Until the 1960s, when, and it was probably Blomberg here, a couple in Sweden, and Inga-Marie Nielsen, who was not quite as old as in this picture, but she was a grad student with them, and they tried to isolate fibrinogen and accidentally isolated factor VIII. And she had a patient in the hospital who was bleeding to death, and she said, can I just have this factor VIII stuff, and can I give this to this patient? This patient happened to be somebody with probably type 2N von Willebrand disease, but them also lacking factor VIII, because the binding is affected, the factor VIII actually helped this patient. So probably somewhere around that time is when factor VIII became available as a treatment to these patients, and that started normalizing people's lives and really made us enter what I want to call the factor era. Factor era, where we had the first factor infusions, and pretty fast hemophilia centers started forming, and the thought was, well, it's not good enough if the patient is bleeding at home. They need to travel with this bleed to us, but should that treatment not be in the patient's home? So in showing the patient how to infuse, how to take care of themselves, and seeing whether we can get these factor concentrates into the patient's home. So unfortunately, as per, and I'm not going to go into detail, but in the 1980s, unfortunately, the blood supply, because all these factor concentrates were derived from plasma, were contaminated with HIV and hepatitis C, which is a dark area for hemophilia. But since, and during that time, we started having a network of national hemophilia centers to take care of these patients, to deliver home care, to surveil them through the CDC for hepatitis C and HIV. So this is a tight network of 150 hemophilia centers in the country probably at this point, and we work together very closely to deliver comprehensive care to our patients. Since then, in response to the HIV and hepatitis C, we had the first monoclonal factors, we had the recombinant factors, and then finally somewhat longer acting factors. But And with this, we started to be able to give people prophylaxis, so not chase the bleed as it happens, but to prevent bleeding. And that's standard of care. And with that, in the United States or in the Western world, this is really what we're thriving for in hemophilia. We want our kids to be normal. We don't want them to play American football, but we want them to be running. We want them to have healthy lives and active lives. So this is where we are in hemophilia at this point. What are the challenges then? These kids seem to be pretty good. We've come a long, long way. So what is the challenge today? The challenge today is that all these factor concentrates still have to be given IV. There's no subcutaneous, there's no oral. People are working on that, but either you can't deliver enough or you're getting a subcutaneous immune response. So it remains IV. That means from the day they're born, they're lacking this factor, and somehow that factor has to go into that little child, which often means that we need central lines when they're little, and especially if you're looking at this, and that's a typical prophylactic regimen, is that we have to give factor VIII because of its half-life about every other day. Sometimes we just go with a higher dose over the weekend, so we can kind of keep that on the same days, but it still means a high infusion burden. Just picture yourself with a son that you're gonna have to infuse IV several times a week. So still a huge burden. Some people don't have good venous access, and they need ports. Ports get infected. And this is all being done at home, so we have to teach the families. So still a relatively short half-life, really for hemophilia A, much, much more so than hemophilia B. And that has triggered this thought, well, can we prolong the half-life of factor? And there are now, and I'm not going to go into details with that, but there are now several new agents on the market that have extended half-life. And for factor IX, that half-life extension really has been quite striking. And a lot of our hemophilia B patients can now do an IV infusion once a week, every 2 weeks, and lead relatively normal lives. So in hemophilia B, we're much closer to a normalish life, but for hemophilia A, that's not quite there yet. So if you're looking at one of these products, this is the standard half-life product and this is the extended half-life product. And I'm going back to this, what is our goal of prophylaxis? Remember, I told you the 1%, it seems to be a magical number. If I'm over 1%, maybe I don't have the spontaneous bleeding because now I have moderate hemophilia B. If I'm less than 1%, I have severe hemophilia B. So we're always looking at this 1 to 3%. This is what our trough should be before we start dosing again. And if you're looking at these comparisons in this clinical trial, the standard half-life factor, it took about 3.3 days to reach 1%, which is pretty little bit longer than what we really see in clinical practice. And with extended half-life factor, we're only getting to 4.9 days. Still means several injections a week. So not really quite the answer we were hoping for yet. And the other problem is that especially in hemophilia A, and especially in severe hemophilia A, and that kind of makes sense, we have an immune response to this infused factor. So that's antibodies, they're IgG antibodies against factor VIII. They're also called inhibitors because they're inhibitory. They render the factor VIII infusions or less hemostatic or not hemostatic. And about 30% of people with hemophilia A, with severe hemophilia, get this immune response. And that means they can no longer replace this factor VIII. So that means that we have to do something else in them because factor VIII doesn't work. And the attempt that's been shown to be somewhat useful is to either give them factor VII, activated factor VII, which is a very thrombogenic, with tissue factor bypassing modality. Factor VII has a half-life of 2 hours, so it has to be given intravenously several times a day to treat a bleed. And prophylaxis, though it can be done, is not very or not as good as factor VIII prophylaxis. And then we can also give an activated prothrombin complex concentrate, or APCC, which contains factor II, 7, 9, and 10, trying to find other ways to bypass this need for factor VIII. That has to be given about 2 to 3 times a day, so still a lot of IV infusions, and it's not as effective as factor VIII. So really not optimal. And the only way to get rid of this inhibitor is with immune tolerance, which is daily very high doses of factor VIII. Usually it takes on average 9 months of doing that before the inhibitor may go away, and often it doesn't at all. So these people are kind of stuck with not great options, and we're going back to the pre-factor era in a way. So what's on the horizon? I'm going to talk a little bit about gene therapy. Like I told you, where are we? Are we going to get a cure for all this? That certainly would help us with all these injections. With the inhibitors, not sure that that's going to help us. Maybe that's the ultimate immune therapy. I'm not sure. And in the meantime, we have these really exciting subcutaneous agents that I'm going to talk about. So let's talk about gene therapy first. This is an initiative probably that was started in the genotyping of factor VIII and factor IX that was heavily started and propagated by Art Thompson, who's in the room, and then was taken up by a project called My Life, Our Future at Puget Sound Blood Center and now Bloodworks Northwest. And Jill Johnson has been very involved in that, identifying hundreds of different mutations in factor VIII and IX. There are all kinds of mutations, and the mutation very much determines how severe the hemophilia is and how likely people are to get these inhibitors. The target for gene therapy, if we're looking back, and this comes back to this magical 1%, how high, if I give gene therapy, do I need to cure this person? Do I need to get them to a normal factor level? Or is it okay if I just raise it a little bit so I can take somebody from severe hemophilia and make them moderate or mild, and hopefully they're not going to have the same scenario? So this is a publication that shows how likely you are to have annual joint bleeds and how that correlates with the factor VIII activity. And you can clearly see if you're under 1%, you're much, much more likely to bleed. That drops very, very fast. In particular, when you're getting to more than 5% trough, you're really much less likely to bleed, and probably at 11%, that really levels out and you're not very likely to bleed. If you're getting challenged, if you have surgery, if you have major trauma, you're still going to bleed, but all this spontaneous bleeding is probably not going to occur. So kind of keeping this in mind, what is our goal for gene therapy or for any subsequent therapy? What has been tried is to use the Adeno-Associated virus, AAV. We know that wild-type AAV is a parvovirus. It's non-pathogenic, and it naturally infects human beings. So there's a recombinant AAV, which happens to be liver-targeted, and that's where we want to go. We want to direct whatever capsid we have, whatever virus we have, so we can deliver the factor VIII and IX gene to the liver, because that's where it's naturally made. There's no viral coding sequence in the recombinant AAV, and it's predominantly non-integrating. So far, it's shown excellent health and efficacy profile in animal models and in human trials. So the idea is that you would give a single vector administration, and hopefully you would get therapeutic factor expression level and hopefully have long-term efficacy. That's the overall goal. That's what we're striving for. And this was an initial try with an AAV-2 vector, or one of them. And I just want to show that to illustrate here, and this was done in factor IX at first, because it's a much, much smaller gene than factor VIII, so easier to get into the capsid. So here in red, you see the factor IX levels. And you see this individual, for example, kind of has a really nice response initially, but then unfortunately we lose that. And that was in association with liver enzyme elevation. So it seems like there's an inflammatory response in the liver and we lose the vector. Then here's somebody who initially had a little blip, but then that went away. And then here's somebody who never expressed any factor IX. So the question is, why is this happening? We really need to figure this out to be able to have mitigating or mitigation of that so we can make this work. So the question is this a humoral cell response that you have a pre-existing humoral immunity to it, and therefore you're not going to get any gene expression in the first place? Or is this a classical cytotoxic T cell response, often CD8 driven, that leads to the elimination of the AAV transduced cells? So maybe that's where we see those liver enzymes, initially it seems like you get levels and then you lose them. Or is this an innate immune response? Wild type AAV, not known to do that, but what is happening when we have this recombinant AAV? So this is a kind of a summary of what we know about the immune response in the population this is taken from different clinical trials with all these vectors, whether it's AAV-2, FIX, FVIII, FIX, and this is how prevalent the immunity or antibody binding is to that. And you can see, especially with AAV-2, it's much higher. So AAV-8 and FIX might be better targets. And that here is an AAV-2 vector. This was a publication that was in the New England Journal of Medicine, I think in 2011. And this is an updated publication. Here are all the individual patients. I'm not going to go through those in detail, but just to show you, so here in gold or in yellow, you see the factor IX levels bouncing up and down because people also got factor IX infusions. And here in green, you see that some patients had this liver enzyme elevation that seemed to then result or be correlated with the loss of the vector. But how are these people doing? These people are now many, many months out from the initial vector infusion, and these are their factor IX levels. So they're anywhere between 2.1 and 7.7. So we are getting, these people are now not severe hemophilic patients anymore. They're now moderate. But the question is that enough? Is that as good as we can get? I mean, I'm sure these people are happy to be higher, but there's still some of them have to infuse factor again. So altogether, that showed, or these people are using less factor concentrate than they did before. And they have less bleeding. But again, is that really the answer, or can we do better? And there are a couple of trials that in hemophilia B seem to be quite hopeful. And there's one of them where this is only 4 subjects, but there are a couple of people that seem to get to much higher levels and so far have stayed there. And here's another trial. And unfortunately, this was from 2016, and I just saw the updated data from this recent ASH, which was just last week. So this continues to go on with several subjects in a phase 1/2 trial that are achieving levels of around 30%. So now we're talking about, we're taking somebody from severe to mild, and I think that is a fantastic achievement and potentially somewhat curable. What about factor VIII? Factor VIII, I told you, is a much bigger molecule, and I think if somebody would have asked me 5 years ago, I would have said, we are far, far, far away from any cure in hemophilia A because we can't get that vector, it can't get that gene into the vector, it's too big. Turns out that factor VIII has this B domain that doesn't seem to be very important for coagulation. So if you delete that, you get maybe a smaller gene. They actually figured out how to get this into a vector. And this is a very, very, very impressive trial data that's coming out, phase 1/2, that was initially presented at the World Federation of Hemophilia. And they just gave an update at the recent meeting. But this is on average what factor levels the median factor levels they achieve. These are the weeks, and these are all the subjects and how only 7 subjects, but they achieved normal factor levels. This looks really, really, really impressive. But then if you tease that down or tease that out, these are the median, this is the range. So you have a range anywhere from 12% to 316%. Well, 12% is good, but is it enough? And 316, who on earth wants to live there? This is overshooting the mark. So the thought was, well, we really need to fine tune this more. This seems to be very promising therapy, but is it going to get us? I mean, this is very unpredictable. Very exciting. At the recent meeting, they showed the update now at 64 weeks, and the median factor VIII level was 86%. But look at this range. Now the range, these people here are now ranging between 65 and 107. So it seemed like the lower ones came up, the higher ones came down, and we're now seeing these people with normal factor levels, which was really, really exciting news. So there's also a different company that is doing a recombinant AAV. They only dosed 3 hemophilia A patients so far, and they're getting levels of 11 to 14. So we'll see what their next step is going to look like. But I think this looks very bright and hopeful for the future. Not quite there yet. The first phase 3 trials are starting, so we'll see where that goes. And this is just I'm not going to go into detail, but there are a lot of gene therapy trials. There are a lot of subjects that have been treated with gene therapy and hemophilia, and they all seem to be doing quite well with various responses. So while we're waiting for gene therapy to get us where we want to go, and I'm going to be out of a job, we have some subcutaneous options, and I wanted to spend some time on that. So far, I told you with the hemophilia A, that seems to, or with a gene therapy, maybe I don't have to do these infusions anymore, and that's going to be great. But that leaves the people that can't get the gene therapy because they have pre-existing antibodies. They can't get anything. And what about the inhibitor patients that I told you are one of our main concerns in hemophilia? I don't know that I can give them gene therapy. Are they not going to have the same immune response? So there's a gap of people that need therapy, better therapies than what we have right now. And what's in the pipeline are several ways to maybe deliver something subcutaneously for patients, maybe with a longer half-life, where I can inject something maybe once a week, maybe once a month, and get people good hemostasis. And I'll just talk about a couple of them here. The idea is there are these natural anticoagulants. Can I just put the brake on those? And tissue factor pathway inhibitor and antithrombin are 2 targets I'm going to talk about. This is still phase 1-2 data. We don't have phase 3 data, but I just wanted to show you what's going on and what's coming down the pipeline, how we're doing with that. And then very excitingly, this is emicizumab, which is a bispecific antibody that acts like a factor VIII, as I'm going to show you, and that actually can substitute factor VIII. And that is the agent that was recently approved. So I'll talk about that. So like I said, targeting the anticoagulant proteins. And Jan, here's the factor VIII. So the idea is that, well, if I'm missing something in the in coagulation, can I rebalance the coagulation by taking away something else? So if I'm missing factor VIII or factor IX, I'm going to be bleeding. And if I can inhibit an anticoagulant protein, can I then restore coagulation balance? So this is a humanized antibody. There are 2 of them that are being investigated right now. This can be given subcutaneously, so that would be a huge advantage over what we have right now. Seems to have a much, much longer half-life because it's an antibody, so maybe I can give this once a month. This would happen, this could be used for hemophilia A and B. It wouldn't care whether somebody has an inhibitor or not, so it would be great for both of that, and possibly other bleeding disorders such as von Willebrand disease or anything else. So there are 2 trials. I'm not going to go into detail, but just to let you know, there are phase 1 data that are emerging, and there are phase 2 studies that are planned. So we're hopefully seeing some data over the next year or so. The other one is to inhibit antithrombin. So fitusiran is a small interfering RNA. Fascinating technology, but the idea is if you're making antithrombin 3 in the liver cells, could you interfere with the RNA? So by injecting interfering RNA that binds to the RNA, and therefore you're going to limit expression of the antithrombin, really making people antithrombin deficient. And we all know that puts people on the thrombotic spectrum. So if I'm missing factor 8 or 9 and I can make people mildly or somewhat antithrombin deficient, can I get them back into that balance? That can also be given subcutaneously. It can be given once a month. It would happen for hemophilia A and B, with and without inhibitors, and potentially other bleeding disorders. And there is actually some phase 1 and 2 trial data, and we're hoping to see a phase 3 trial in the next year. The antithrombin level in response to the small interfering RNA indeed decrease, and at the same time, the thrombin generation increases. So this is very preliminary in a phase 2 open label study in very few patients. These are patients with hemophilia who are on prophylactic treatment with factor. And on average, they have an annual bleeding rate of about 2 bleeds or 2 treated bleeds a year. If you have somebody who's not on prophylaxis, they're just treating as it comes. In this trial, in this very small population of 12 people, they had 12 bleeds a year. When they were placed on those fitusiran, they went down to 1.7 bleeds a year. So on par with the prophylactic treatment, but given subcutaneously once a month. This is without inhibitors. This is with inhibitors. There are people that had a lot of bleeding, and that's what we see in inhibitor patients. We see a lot more bleeding, 38 annual bleeds, and that went down to 0. So preliminarily, very encouraging results. And after 20 months, they looked at the safety because we were all really, really concerned in the hemophilia community about messing with this antithrombin, and are we just going to push people too much to the thrombotic side? And I think a lot of us were really uncomfortable. So at 20 weeks, we were really encouraged because it seemed like there were no major side effects. There were some injection site reactions, but no thrombosis until that point. Until recently, on September 7th, the dosing was suspended because there was a patient who developed cerebral venous sinus thrombosis after treating a hip bleed for several days with factor. So they came in with headache and nausea, and they did a CAT scan, or the radiologist read as a subarachnoid hemorrhage. So because it was read as a hemorrhage, he got more and more factor 8 on top of the fitusiran, and eventually this patient died because of cerebral edema. They then went back and reviewed the CAT scan, and it actually turned out that this was a venous sinus thrombosis to begin with, so it was misdiagnosed. So because it was misdiagnosed, we're not sure. It was not why did they get a cerebral venous thrombosis? So do we see this, factor 8 and fitusiran really cannot be given together? So I think we're going to have to pay close attention. But I think with mitigation strategies, we're going to see this trial going forward. All right, and now to my baby. This is the bispecific antibody. This is the emicizumab that, or the idea was, well, if we're thinking about how factor 8 works, factor 8 is kind of a phospholipid membrane-bound matchmaker, or it needs to bind to activated 9 and 10 to bring them in closer proximity, and then help factor 10 to be activated. So that's what factor 8 does. So the thought was, can you not have a bispecific antibody that recognizes the activated 9 and the 10 and can do the same thing? And that is what emicizumab or ACE910 is doing. because it's a humanized antibody, it can be given subcutaneously. And right now, I mean, initially the dosing was thought to be once a week, and maybe it can be given every 4 weeks. This will only happen or only work for hemophilia A. Clearly, this is not going to help for hemophilia B, but it's exactly where it's missing. So I'm not messing with the entire coagulation. I'm really targeting where we have the defect. But this should work in people whether they have an inhibitor or not. So this is very, very exciting for hemophilia patients with these inhibitors because it doesn't care whether there are hemophilia A or factor VIII inhibitors around or not. So this is the New England Journal of Medicine that was published this summer that showed the phase 3 results, and I want to go into that a little bit. So the study we did was in people initially, people with hemophilia A with inhibitors, really the population that needs treatment the most. They were 12 years and up. And what we said we're going to do is we're going to randomize them if they're on-demand treatment, so they're just treating bleeds as they come with bypassing agents, then they can participate, and they're going to get randomized to either stay on what they usually do, just treat a bleed as it comes, or they get randomized to get emicizumab subcutaneously once a week. And then they were followed for 24 weeks, and the primary analysis was to look at bleeding rates. Now, when they did have breakthrough bleeding, they could be treated with their bypassing agent. The other endpoint or secondary endpoint was to take people that were on prophylaxis with bypassing agents, so with recombinant 7 or APCC, to have them, to observe them prospectively for 24 weeks to see how much bleeding they had, and to then put them on emicizumab for 24 weeks and compare them to themselves. So the first thing, not the primary outcome yet, but I want to remind you, so factor VIII prophylaxis, again, you have these peaks and troughs and peaks and troughs and peaks and troughs. You have to give it several times a week. And when you are at this trough level, that's when people tend to have breakthrough bleeding. So what we saw with emicizumab is we gave a loading dose for the first 4 doses, which up-escalated the dose. And then after that, we gave it weekly at half the dose. And we found that people had very nice, consistent drug levels. So certainly an advantage over this peak and trough and peak and trough and peak and trough. And this is once a week subcutaneously. So what we found in people, if we compare them, this is people that were not on prophylaxis, the annual bleeding rate, so how many bleeds they had to treat with bypassing agent yearly, was annualized to be 23.3. In the people on emicizumab, we saw that people had an annual bleeding rate of 2.9. You say, well, I mean, yeah, so big deal. I mean, these people are not on prophylaxis, and I'm giving them a prophylactic treatment. So no surprise, big surprise here. What I really like, however, is if you look at how many people had no bleeding. So we found that in only a couple people in the prophylactic arm happened to not have bleeding, but 63% of people on emicizumab in that entire trial time did not have any bleeding. So that was very, very striking, and that was correlated, I don't have the data here, but that's strongly correlated with quality of life, naturally. And people getting more active, and I started getting very concerned in the beginning of the trial because I had all these patients that came in with CPK elevations, and I said, oh my God, the drug is doing something, I don't know what it is. But then I started talking to the patient, always helps. And I had patients that came in and they said, yeah, I did 100 push-ups because now I can, because I'm not getting any bleeding. So really has been a striking difference in this patient population. What about the people that were on prophylaxis before? That's really what we want to know. We want to see, is the standard, is this any better than what they did before? And here are all the 24 individual patients. And in dark gray, you see how much bleeding they had in the 24 weeks before. And again, this is prospectively collected data. So this is not just recall, but they had a electronic diary and they had to put the bleeds in as they happened. So quite a bit of bleeding, as you see, despite being on prophylaxis with bypassing agents. And I think that's an important point to make, is that's the best we can do for this patient population. And in light gray, you see how they did after they were placed on emicizumab. And you can see, even though there are a couple patients, patient 2 and patient 4, they seem to have more bleeding, however decided not to get off the emicizumab. But everybody else had less. And look at this, really, really striking. There are no light gray bars right here. So people are really doing much, much better on the emicizumab prophylaxis versus their bypassing prophylaxis. So these were quite striking results. What about the safety? By and large, the drug was tolerated really well. The majority or the main related side effect was injection site reactions. They tend to be rather mild, a little bit of redness, and nobody decided to leave the trial because of it. What I just want to spend a little bit of time on here is there were patients with unusual thrombotic complications, and we really need to understand them and why on earth was this drug approved despite these complications. So what we saw here is that we had 3 patients that had thrombotic microangiopathy, which is something that we never saw before in hemophilia. So that didn't make any sense to us, and what was going on with that. And then we had a couple patients with thrombotic events. So let me dive into those just a little bit here. The thrombosis, one of them was a cavernous sinus thrombosis, one of them was a superficial leg thrombosis. Neither one of them were anticoagulated, and one of them resolved, one of them was resolving, and one of them even decided to restart the emicizumab, just received supportive care, so it seemed like it was short-lived. Both of them had received an APCC to treat a bleeding episode while on emicizumab. The TMAs, there were 3 of them. All of them also were associated with APCC use, and that's going to become important. They didn't get any anticoagulation. A couple of them were started initially on plasmapheresis. 2 of them resolved, and one of them was resolving at the time. Unfortunately, this gentleman died because he had uncontrolled bleeding, and he did not, for religious reasons, did not want to get any blood transfusions. So, but his TMA was resolving at the time of death. And this one TMA also restarted the emicizumab. So it's very important to look at what is this correlation, where's this coming from? So we looked at all the patients that received recombinant 7. There were 37 patients, 104 were treated episodes. None of them had any thrombosis or any TMA. So it seemed like, at least in this population, there was no complication giving the emicizumab and the recombinant 7. What about the people getting APCC? There were 20 patients, 78 treatments. And we kind of wanted to tease out who are the people that ran into trouble. And if you're looking at less than 100 units per kilogram or more than 100 units per kilogram treatment for less than 24 hours or more than 24 hours, the people that had these TMA and thrombotic events were only in this box. So people that got repeated APCC for relatively high doses for more than 24 hours. So after that, there was a Dear Investigator letter saying you cannot give them as much APCC with the emicizumab. And it kind of makes sense when you think about it. What does APCC have in it? 9 and 10. So these are the substrates for the emicizumab. So that's likely why we're seeing some of these problems. So since then, since that Dear Investigator letter came out, there are no people that have been treated with APCC anymore, and we have not seen any thrombotic complications. And thus, the trial continued to go forward with positive results, and which led to the FDA approval. What about the kids? So this is the pediatric trial. So I showed you everything, how people did that were 12 and older. What about kids? And this was actually people as young as 2 all the way up to 12. These are all the individual patients. This is still an interim result. This is updated, was updated just recently last week. This is the data from last week. So in orange here, you see how much bleeding. These are kids on bypassing prophylaxis. So they're getting recombinant 7 every day, or they're getting a prothrombin complex concentrate every other day. All these kids have ports because that's the only way to get the drug into them. And despite that, here in orange, this is the annual bleeding rate. So they're still bleeding quite impressively. In blue, you see how they did on emicizumab, or you barely see it, because most of the kids really were not bleeding. So this is changing the life for these kids. We have now removed a lot of the portacaths because they're not bleeding anymore, and they're just getting their weekly emicizumab, and they're running around, they go camping, and they lead relatively normal lives. What about side effects in that population? There was most of the related side effects were, again, injection site reactions, but nothing that they were taken off the drug for. There was no thromboembolic events. Now, in this patient population, because they bled so little, we also didn't have to give any bypassing agents, and that's probably why we didn't see any thrombosis. But certainly the Dear Investigator letter and the caution of giving APCC, I'm hopeful that we're not going to see an awful lot of thrombosis in the future. Oh, and very importantly, not in this trial and not in the adult trial did we see any drug antibodies. So emicizumab for non-inhibitor patients, it's not approved, so this drug is approved for inhibitor patients alone. This is a phase 3 trial that is currently ongoing. There was a press release recently that showed that this trial has met its primary endpoint, and it seems that emicizumab is better than not being on prophylaxis, and it also seems like emicizumab is better than factor VIII prophylaxis. So we'll hopefully the data is going to be presented in spring, I hope. And that's going to be exciting data to see, and see whether that's going to get approved. So remaining questions, considerations with emicizumab. So this is important because these patients are now going to be on emicizumab. They're going to be admitted to medicine. What do the laboratories do on emicizumab? The APTT corrects immediately when I just sniff a little bit of emicizumab at the patient. So the APTT in these patients is not going to be a reliable result. So you cannot no longer, if somebody on emicizumab comes in, say, yeah, they're fine, their APTT is corrected. That is not necessarily true. It just means that they probably took emicizumab sometime in the last couple or 3 months. The half-life of emicizumab is 28 days. So it means it's going to take several months before emicizumab is out of your system. And because of the APTT, because the one-stage factor VIII clotting assay is APTT-based, this is not going to be a reliable measure. So we cannot run regular factor VIII levels. A regular factor VIII level on a patient on emicizumab is going to be 300 or something, and that is in the test tube. This is not real life. So please don't put these patients on anticoagulation thinking that they're normal. So what we have to do is a chromogenic factor VIII assay, which is a 10A-driven assay. And here it's important that the reagents we use have to be, if we want to see how much emicizumab is in the sample, we want to use a human chromogenic assay because it's a humanized antibody. If we want to see how much factor VIII is in this naturally in this patient, we can use what's available, which is a bovine chromogenic assay, because it doesn't take the emicizumab under account. But we still don't really know how the levels are affected, and it's not going to give us very reliable measures. So that's kind of, we're investigating that right now to see what we do with levels and whether we can get drug levels instead. So I think that's going to be coming soon. Considerations with emicizumab. So I showed you this beautiful steady state, and that's the same whether you look at the kids and the adults. They seem to have similar pharmacokinetic profiles. This gives you a factor VIII equivalent of about 15 to 30%. So it does not normalize patients. So patients on emicizumab are really people with mild hemophilia. So if they're in a car crash, they're not 100% protected. If they're need surgery, they're not going to be 100% protected. So we really need to figure out what to do during that time. It certainly has been shown to prevent bleeding. I've shown you the data. What about breakthrough bleeding? How do we treat them? Probably at this point with some recombinant 7, I would really try to stay away from the APCC. What do we do for surgery? So now, I guess yesterday I got a consult and somebody who needs a AAA repair. How do I do that? I really am talking about factor VIII equivalent levels of 15 to 30%. That's not going to be enough. There's an appendectomy that was done in the phase 1 trial, didn't get anything else and did well. And I recently at the conference presented the minor surgery data, so surgeries that happened on the clinical trials. They were not planned, but they just happened because we took ports out or people needed a biopsy or something. There were 29 surgeries. 1/3 of them, people said, I don't feel comfortable with the emicizumab alone. I'm going to give a bypassing agent. And of those, 2 of them, or 11%, had some post-op bleeding and needed further treatment. 2/3 of investigators said, I trust that emicizumab, it's going to do fine. They did not give prophylactic bypassing agent. And here, about 1/4 had post-op bleeding, but only 2 people, or 11%, needed treatment. So it seems like for minor surgeries, maybe you can get away with careful observation, and you might not necessarily need a bypassing agent, depending on where the location is of the bleed and what the procedure is. But I think for major surgery, we definitely need additional prophylaxis. How important is factor VIII for tolerance? So now we have this great subcutaneous treatment. Can I have this hemophilia baby that is being born and start them on emicizumab right away? That means that I will never expose them to factor VIII, which might be okay, but now the baby is 12 and is in a car crash or needs surgery, and now I want to give factor VIII. So at that point, that kid is much, much more likely to make an immune response. So the question is, when is tolerance most likely? Do we want to start these kids on emicizumab right away, or do I want to give them some factor VIII first to kind of expose them maybe at low doses to get them used to it? How likely is the inhibitor formation during a time of surgery, of trauma? Am I making it more likely for them to have it? And do we in the end care, or do we just say, well, maybe we can push the dose of emicizumab eventually and make them normal? And maybe there's gene therapy. Are we ignoring other potential functions of factor VIII? There is some data that is coming out in a mouse model that demonstrated if people are lacking, or if mice are lacking factor VIII, they have less bone density. So is that something we need? It's also in a mouse model from OHSU, it showed that not only are the bones of mice not as dense, but they also break more easily. So I think it's something, as we're going forward with this emicizumab, is what are we missing? Do we need to be more careful that these kids and these adults are not becoming osteopenic and osteoporotic? So kind of think about the other things that factor VIII may do besides just coagulation. What about the thrombotic risk? We talked about that quite a bit, but this was all in controlled clinical trials. I'm a little afraid that people are going to start on this emicizumab and people are going to throw all kinds of agents at them. And are we going to see more thrombosis once it's in real clinical use? I think we need to pay attention to that. The annual cost right now is, on a prophylaxis patient for an adult, is about $450,000. So that is going to be a very expensive treatment. So is hemophilia, period. But what can we do to eventually reduce this burden to healthcare? And how is this reimbursed? We're actively trying to figure this out. It looks like insurance will reimburse it, because the $450,000 a year, believe it or not, is cheaper than prophylaxis in an inhibitor patient. Considerations with gene therapy. Right now, we only have phase 1 data. We're going to see, it looks promising, but we're going to have to see, what do we do with the immune response? Who can take it and not? What level is enough? Is 5% enough? Do we need to get completely normal? How long does the response last? This is in long-lasting or longevity liver cells, but eventually do they die off, and do I lose the vector? And then, because of the immune response and the previous exposure, it's not like I can dose them again. What will that cost? I have no idea. What's the long-term safety? We don't know. And will this work for inhibitor patients? So I think what we're seeing here is we're coming from an era where we talked to our patients about knee replacements and orthopedic surgery because of all the long-lasting effects of these continuous bleeds, intravenous access, the factor era. We certainly got better with putting patients on prophylaxis. We have longer half-life factors, but not quite the answer yet. And we're really going to a new era where we're getting away from factor. We have these non-replacement therapies that I've talked about. We're hoping for gene therapy. There's a little kid of mine, I showed that the other day in Hemogran rounds 2. This is his second injection of emicizumab ever. And he said, I want to do it myself, and I want to show the world that it can be done. He's 6 years old, and he really wanted me to show this picture to you. So that's very, very different from teaching kids to do their own IV infusion. And I really think we've come a long ways, and this is an exciting time for hemophilia. We are still going to need hemophilia treatment centers to guide how these new agents are going to be adapted. That's why we have the Washington Center for Bleeding Disorders at Bloodworks Northwest. This is our team. We work really closely with all the pediatric centers around here. And with that, I'm open for questions.